What we're going to need to think about, we've got to differentiate between the central nervous system, which is the brain and the spinal cord, and the peripheral nervous system, which are the nerves that come out of the central nervous system. The central nervous system tracks synapse onto the peripheral nervous system and go out to the other side of the body. So it's useful to have that distinction in your mind. And there's a schematic there. So you've got the central nervous system, the brain and the spinal cord at the top, and there's a lot of communication within that where you get integration and control going on. And then you've got the peripheral nervous system, some of which sends messages up to the central nervous system, some of it receives information down from there. And this is the cranial nerves and the spinal nerves. Most cranial nerves below the nucleus are classed as peripheral nerves. That peripheral nervous system is divided into sensory, which is the upgoing or afferent division, that's supplying information up to the brain, and the motor, which is taking the instructions from the central nervous system down and out to whatever effectors there are going to be, whether they're muscles or glands or whatever. And this goes into the somatic nervous system. Also involved are the autonomic nervous system, sympathetic and parasympathetic, but from the point of view of testing, we're not really going to be interested in those at the moment, not directly anyway. What we are going to be interested in is the motor side and the sensory side, and probably differentiating between the central and the peripheral nervous systems. The connections are made by neurons, which is a specialised cell within the nervous system, and there's effectively three types of them. The sensory ones carrying the information upwards, the motor ones carrying information downwards, and what everyone forgets about is that they will talk to each other. There's interneurons in between. And I think they're responsible for a lot of the slightly strange effects that you might get when you just think about sensory and motor. You've got to realise that there's a lot of background exchange of information going on at different levels within the nervous system. And that's a picture of it again. That's a motor one, going to be working on the muscle. That's a sensory one, picking up information from receptors in the skin and taking them up. And although these are heading up towards the brain, there's all this kind of network between them where they each know what the other's doing. Not all nerve fibres are the same. There's effectively three types, A, B and C, and the type A ones are further subdivided into alpha, beta, gamma and delta. And all these different types are different diameter, and they carry information at different conduction speeds. Some of them are myelinated and some of them aren't. So some information needs to be dealt with very quickly, so that it's sent along large myelinated fibres. Others, information can kind of chug along at a slower rate, and so it's sent in thinner fibres that maybe aren't myelinated. And not that I'm expecting you to remember it, but there's some instances there of what the different types of fibres might actually be doing, and the whether they're large or small. That's the same information in a slightly different way. You can see the larger ones are on the left, the smaller ones are on the right. The motor ones tend to be large. The sensory ones can be large and can be tapering down. And then a lot of the autonomic stuff is the smaller, slower acting fibres. The nerves are composed of bundles of neurons arranged in things with various names, fascicles. The axons of nerves, the axons of neurological tissue in the peripheral nervous system are grouped together like this, and the names of those groups are nerves. So this collection of fascicles of different neurological cells, this is called a nerve in the peripheral nervous system. A similar kind of arrangement in the central nervous system tend not to be called nerves, they're called tracts or fasciculi or lemnisci, depending where they happen to be. So nerves are actually in the peripheral nervous system. In the spinal cord, the ascending and descending tracts are kept together. This shows you the ascending tracts on this side and the descending tracts on this side. It doesn't mean that it goes up one side and down the other. You've got the same, a symmetrical arrangement, but it's just these ones have been highlighted as being the motor side of it, the descending ones, and these ones are kind of flaked out there, and the reverse on that side. There is a kind of sense, though, that if you think of a front-back split to the spine, the ascending stuff goes up the back, and the descending stuff goes down the front, to an extent. If we think of the descending tracts, the motor ones, they're all listed there, or the majority of them. The ones that we tend to be interested in are the corticospinal tracts, the lateral ones and the anterior ones. The other ones are obviously important, but they're not ones that we tend to directly test. They tend to be part of the way that the body does its housekeeping in terms of motor information. Like the corticobulbar ones are effectively the ones leading to the cranial nerves, and they're the tracts that are above the cranial nerve nuclei. Some of these other ones are related to the way the body is sharing information from different systems. Like vestibulospinal is the carrying the input from the vestibular apparatus to have unconscious motor movements related to keeping you balanced. And so all of this kind of thing happens in the background. But the ones that we're mainly interested in testing are the corticospinal tracts. You hear this phrase, the pyramidal system, and that is the corticospinal tract and the corticobulbar tract. As I said, the corticobulbar are the ones that supply the cranial nerve nuclei. The reason that it's called the pyramidal tract or pyramidal tract is that an early anatomist, when they were looking at the anatomy of the brainstem and the medulla, they found these areas here, which they thought were vaguely like pyramids in shape, and these areas take most of these nerve fibres from this kind of tract. So it goes through these pyramids, hence it was called the pyramidal system. So if we think about the corticospinal tract, remember this is an efferent and motor tract, and it's starting up in the motor cortex. It comes through various parts of the brain itself, through the brainstem, pons, and into the medulla. And most of these, the ones that start on this side of the body, so the patient's right-hand side, would actually cross in the medulla to the opposite side and would travel down the left lateral corticospinal tract to the point where they were going to be synapsing onto the peripheral nerves that come from. About, depending which book you read, 80 to 85% of them do that. The remaining kind of 15 to 20% don't cross in the medulla. They stay on the same side and they descend on the anterior corticospinal tract on that originating side. So most of them cross over in the medulla and go down the left lateral tract. 15 or so % of them stay on the same side and descend in the anterior corticospinal tract on that side. And then when they get to the level that they need to be, they cross over at that level and then synapse onto the peripheral nerve there. So you get this business of the right side of the brain controlling the left side of the body, but there is an element of it that stays on the same side.
What's the point if it's the 15% staying on the left side and go down the anterior if it crosses at the spinal cord anyway?
I think you'd have to ask whoever designed this, but I think the idea is that if you get a damage on one side of the spinal cord, you don't lose all your function. There's a degree of redundancy in the system.
Are lower motor neurons the same as the peripheral?
Effectively, yes. Yes. We're going to get to that now. The upper motor neurons are the ones that come up here, and they're in these tracts. Then they synapse onto, when they synapse into the peripheral nervous system, they become lower motor neurons there. And I've heard it described that the upper motor neurons are a bit like the parents, and the lower motor neurons are a bit like the kids. The kids are under the control of the parents, and if you get an absence of that control, or in this sense they call it inhibition, then the lower motor neurons or the kids run wild. That's why if you get an upper motor neuron lesion, some of the tests that we do provoke things like excess muscle force, stiffness, or very brisk reflexes and things like that. They are overreacting because they lack the inhibition that's coming down, or the control that's coming down from above. That. Yeah, pretty well. So that's the same thing in a different view. You can see the split, you can see the left and right shift, and you can see the point where this one having crossed up there, synapses here. This one having stayed on the same size, crosses there and synapses there. These are the lower motor neurons forming the peripheral nerves coming out. Well, not technically forming the peripheral nerves at that time, but the lower motor neurons come out. They'll join further down to form nerves. And that is the peripheral nervous system in there. I've covered all that. And that's again the close-up view of the decussation, this time starting on this side, coming down here, through the various parts of the brain, into the pyramid, and crossing over like that and going down there with a small fraction staying on one side. Same information, just a different form. Can you see it? Am I standing right in the way?
It's fine.
So if we're going to test this, like we said before, we're going to observe. And from a neurological point of view, one of the first things you want to do is check for muscle wasting or muscle fasciculation. If you lose the peripheral nerve supply to a muscle, that muscle can't coherently act anymore. And we've got this sort of use it or lose it thing. So if the muscle's not being energised, it can't work, and if it doesn't work, it wastes away. So you get muscle wastage. When you get a muscle wasting, because when a muscle normally contracts, you get the coordinated contraction of a load of different muscle fibres all together, which gives you the muscle contraction. If you lose that control, what can happen is that individual fibres can get locally irritated and can kind of fire off individually without being coordinated. And you get this kind of sense of moving, sort of writhing movement in there, which are these muscle fibres just triggering off by themselves. And that's called fasciculation. So in a lower motor neuron lesion, you tend to get weakness, loss of power, muscle wasting, and fasciculation. So that's the sort of things that you might see in your observation in the sense of a peripheral nerve. Tonus and clonus. Tonus is Latin or whatever for muscle tone, and tone is defined as the resistance of a joint to passive movement. So if I pick your arm up and move it around like that with you allowing me to do so, I'm used to a normal degree of resistance of your body caused by the background muscle tone. So if I pick somebody's arm up and move it around, I'm checking for that normality. If it's looser than I expect, if the muscles are very flaccid, it might move more easily. If the muscles are being over-stimulated, it might be much harder to move. It might be stiff or rigid to move. And there's another thing called clonus, which is if we provoke a muscle where there is an upper motor neuron lesion, then that muscle might overreact and kick back against us. I'll come back to that in a minute. In fact, I'll just do it now, it saves a minute. In some types of upper motor neuron lesion, there are typical postures that people have. The typical hemiplegic posture is the upper extremity to be fully flexed like that, and the lower extremity to be fully extended. So they're kind of walking like that. Okay? That is the effect of, like I said, the lack of inhibition, making those muscles tighten up. So the upper one goes into full flexion. The lower one, if you think back to the embryological state, or the fetal state, the legs were round the other way. As the fetus develops, the legs turn outwards. So what was flexion becomes extension. So when you go back to the kind of primitive state, with the flexed upper thing, what you're actually getting is the effect of a flexed muscle in the fetal state, but it turns out to be an extended leg in the adult state. Now, that's the effect of constant muscle tone in those areas. If they're heading towards that, you might find that if you provoked the flexor muscles of the upper extremity and the extensor muscles of the lower extremity, you by provoking them, by stretching them, you might find they kick back at you. And that kicking back is clonus. And we've got, we'll do the practical of that when we get there. So, observation, checking for tone and clonus, and then you check for power. The muscles supplied by a particular nerve root is called a myotone. So each myotone you check for the power in the muscle using a standard power test. You can then assess reflexes. We normally do 5, 6, 7, possibly 8, 3 and 4, and S1 and 2. And they're called deep tendon reflexes. I'll talk about them more when we get the slide to it. There are some other reflexes, which are skin reflexes or superficial reflexes. The one that people call the Babinski one, which is the plantar reflex. And there's one, not a very reliable one, on the abdomen, where you can stroke either side of the umbilicus and see if the umbilicus is drawn towards the stimulus. They're not the same types of reflexes, but they are reflexes nonetheless. Then the other testing, all this lot is to do with power, and then we can go on to sensation, which we would test with pinprick, temperature, vibration, joint position sense, stereognosis and graphesthesia, or some proportion of those. You don't necessarily need to do anything. And then you can also consider at the same time cerebellar testing, which is moving slightly away from the basic motor and sensory, but we might as well consider it in the same breath, as it were. Yeah.
Do you always test motor before sensation?
Not necessarily, no.
Just a bit.
No, I just happen to be showing you. Most of these things, there's no right and wrong way of doing it. We, when we're testing the students, we'd rather they did a way that made sense to them. The only thing that we would say is do the least invasive test first. Just before you do anything else, because you might change it. But if you want to do sensory before motor, that's fine. If you want to do motor before sensory, that's also fine. No problem. So, in the history, what sort of things would make you think of a neuro test? If they talk about unexpected weakness, I can't hold my teacup anymore. I keep dropping it. I used to be able to open bottles easily, now I can't. If they talk about being unable to move something, that's obviously paralysis, but if they find something is, it's more, it seems my legs are very heavy, it takes me more effort to kind of pick my knees up, as it were. That might make me think of some degree of difficulty of moving the muscles, so paresis, paralysis, something like that. Stiffness, we talked about before, about the rigidity. That might show the patient as on my arm's gone stiff, can't do anything with it. Unexplained falls. Yeah, someone comes into you, oh, I've sprained the ankle. Oh, fine, let's have a look at your ankle, da-di-da-di-da. You might not think, well, why? How did you do it? I fell over. Well, why did you fall? Did you trip over? Oh yeah, a little dog ran out in front of me and I fell over it. That's fine. Well, no, I don't really know. Just 1 minute I was walking, the next minute I was lying on the ground with a sore ankle. Might make you think, well, what caused her to go in the first place? So it may be that the presenting symptom is not what you need to be looking at. So anything unexplained, you might want to do a neuro exam. This word numbness, to us, something being numb means there's no sensation there. If I stuck a pin in it, you wouldn't feel it. That doesn't necessarily mean what the patient means by numbness. They tend to use the term numbness to mean a paresthesia, an altered sensation. They might use numbness, tingling, pins and needles, all to mean the same sort of thing. So if they use any of these words, it's probably useful to question them, to get them to tell you exactly what they mean. And if you say, well, what do you mean by that? Well, numb, it's just numb. Well, if I stuck a pin in it, would you feel, oh yeah, of course I would. Well, it's not numb then, is it? So tell me what, exactly what you mean by that. But anything in terms of altered sensation, and going along with that, altered dexterity, I can't seem to do a button up, or I used to be quite good at sewing, now I can't really direct the needle very well. Anything like that, that might indicate the need to do some kind of neural test. That's what they tell you. Observation, postural changes, like I was saying before about that hemiplegic thing. Gait change, get them to walk. Do you remember Morse, John Thorne, when he walked like that? Foot drop. That's a lower motor neuron lesion on that side. We talked about wasted fasciculation. Myoclonic jerks, that's, if you're sitting in a chair dozing and then all of a sudden you kind of do that, that movement like that is a myoclonic jerk. Now, that's normal if you're half asleep and suddenly coming back to working. But if they kind of pepper your normal use, that might be an indication that there's something going on.
What causes it when you're falling asleep and then?
I think it's a question of, I was saying about the lack of inhibition coming from above. When you kind of drift off, you get into that kind of half state, and then you lose that initial control, and your lower motor neurons just kind of kick off a little bit. So, something like that. There's various other gait things, which I've got a slide I'll show you in a second. In fact, it's there. You can see there's various things. If you've got a cerebellar problem, you might have a kind of fairly wide stance, trying to hold your balance because you can't coordinate very well. That steppage one is the Morse one, where because your toes are not being held up, you have to lift your knee very high to clear it before you stick your foot forward, and then when you put it down, it kind of flops down because the toes touch first before the heel. If you've got Parkinsonism, the Parkinson people have difficulty starting movement and stopping movement, and they tend to be a bit unsteady, and they kind of go forward and then kind of move in short steps like that. So you get these different classical things. Sensory attractive, if you lose the feedback from the position, the proprioception in your feet, you tend to have a wide stance and kind of stamp when you go to it, so you reassure yourself where your feet are on the ground. You're not getting the feedback. So any of these things that might be drawing their attention to you when the patient's walking, you might be able to clock in and see what area of the nervous system is involved. When you're doing motor testing, tone, muscle tone, the possibility of clonus, the power in the sense of the muscle being sort of switched on all the time, and the reflexes all tend to be increased in that area in the terms of an upper motor neuron lesion. But they tend to be decreased in terms of a lower motor neuron lesion. So if we're doing muscle tone, resistance of passive movement, as we said, we test one or more joints in each myotome, and you articulate the joint and you just decide whether you think it's normal. Can I borrow this? Yeah. So if she's just lying down, I'll just let you run relax. I might just move it around like that, move it around like that, and just see, am I getting a normal resistance to that movement, or is it more floppy or more rigid than I expect? If I wanted to do clonus, I might do that and just go 1, 2, 3 and hold, and that doesn't bother her at all. If she was tending towards an upper motor neuron lesion, that might kick back at me. So we can do that, and we would do power testing in there. If you get the tone test, and it's not all nice and easy like that was, but it's a bit stiff, a bit difficult to move, and she's not deliberately resisting me, it's coming from the body, then you might want to analyse it a bit further and see what type of rigidity you've got. You can get what they call, what used to be called spastic rigidity, which is also called clasp knife. So if you try the movement, there's a resistance, and then all of a sudden it gives, like opening a penknife. You have to put more force in, and then the knife suddenly opens. And then to close it, you've got to put more force in, and then it suddenly closes. It's just that kind of threshold that you've got to get over. That's called clasp knife rigidity. Or you might find that it's stiff throughout the range of movement. So it's a bit more difficult to move all the way around. They call that lead pipe rigidity. It comes from the old days when they used lead plumbing. If they had to bend a pipe round the corner, they had to put a constant force around it like that to make it go. So lead pipe rigidity. And you can also get this thing called cogwheel rigidity, which you see in Parkinsonian conditions. It's often found if you do this movement, if you do like that, then you sometimes find that it's a bit stiff, but it kind of moves in little jerks, like a cogwheel going around. And that is a Parkinsonian tremor superimposed on a lead pipe rigidity.
Why with the clonus, why is it flexors that's provoked in the hemic
Why is it the
why
flexors?
flex
I think because you're reverting to the fetal position. It's going to a primitive stage of your development. When you're in the womb, everything's flexed up like that, and the legs are also flexed. It's just the hips are around the other way. So in your body's almost being forced back to a primitive stage. Myotomes are the areas or the muscles served by a particular nerve root, and so it's useful to have. You only really need to test the power in one myotome to prove the source, if you like. If we're talking about neurological things, obviously, if we're talking about individual muscles having a problem, it's a bit different. But if you're talking about the neurological side of it, it's a bit like checking the electric wiring. So as long as you've checked everything that's coming from the same fuse, you're kind of okay. So you don't have to do all the every particular joint. Just have the joints that are related to the nerve roots you're interested in. And straightforward power testing, you work out the joint that you're interested in and get the patient to oppose or to exert force against you. Again, if you depending which book you read, you'll see you want a full-blown contraction, a full strength. I would probably argue with that. If your patient's an Olympic weightlifter and you're a fairly slightly built person, if they do a full contraction, you're going to be flying across the room. What I suspect is a better way to do it is for you to get them to resist you, and you decide the amount of force you're going to put in them, and then you can make your own assessment of whether there's any weakness showing up on one side or another. But we'll do that when we do practice. So this is just different ways of showing it. That's the quads power. There is this power grading. Most people these days just seem to say whether it's there or not, or whether it's weak or whatever. But there is a standard grading system that you may want to use if you don't use it. So 0 is where you can't detect any kind of muscle contraction at all from the patient. 1 is if you get them to contract a muscle, you can feel it trying to go if you palpate the muscle, but you can't really get much movement out of it. 2 is they can't move against gravity, but they could move if you take gravity off. Then 3, you can move it against gravity, but not against resistance. And then 4, against some resistance, but weaker than you think. And then 5 would be normal. So there is that grading system if you want to use it, or if you see in somebody's notes that someone else has used it. But I must admit, all the notes that I see just say power present and equal, or reduced, or something like that. Reflex arms. We talk about deep tendon reflexes, which I think again is a slight source of confusion, because it makes people think that Golgi tendon organs are involved, and in fact they're not. When you do a reflex, this type of reflex, the patellar reflex, what you're doing is applying via the geometrics of this knee, you're applying a sudden stretch to the quadriceps muscle. Within that muscle, you have muscle spindles, which are sensitive to their length. If the muscle's lengthened, they get lengthened, and if the muscle's shortened, they get shortened. If you get a sudden increase in the length of the muscle spindle, it sends a sensory afferent signal to the spinal cord, the dorsal cord, and immediately you get a synapse across to the ventral bone, affecting the motor supply to the same muscle, and it causes that muscle to tense up against the lengthening that it was put to. So that all happens at spinal cord level. The brain knows about it, but not till after it's happened. The message goes up there to the brain, but it doesn't go up and then the brain says, oh, react to it. This is the reflex arc around there, and that is governed by the muscle spindles. There is a similar thing, not caused by muscle spindles and lengthening muscles, but a sensory reaction to something like a sharp contact or a burning contact, where you would get an input from the sensory receptors, which would again go into the sensory arc across here and contract the muscle that would pull the arm or the limb away from what that danger was. And again, that happens at spinal cord level. You don't have to wait for it to go to the brain and come back again. So they're the reflex arcs that we talk about.
How do you override that when you're like holding a hot plate, not to
I think if you can consciously override it, but if you touch the hot plate without realising it was hot, you'd probably drop it. But if your brain can often tell your body what to do, and it can say, expect this to be hot, so you can kind of override it. But I don't think you'd override it if you touched it and you didn't know it was hot. Just for completeness, the Golgi tendon organs, I tend to think of these as a bit like mechanical fuses. This is like a strain gauge that is sitting in the tendon and measuring the amount of force that is trying to pull the tendon apart. Tendons don't stretch. If they stretch, they wouldn't be any good as tendons because they've got to be dimensionally stable in order to pull the bone with the muscle. So what the Golgi tendon organ is doing is kind of monitoring the force that's trying to stretch that tendon. And if it approaches a critical level where the body thinks that the tendon's going to get damaged, then it will cut the power to the muscle. So it's like a kind of circuit breaker on there. And I think that's why, kind of picking up on what you said just then, you hear these stories about little old ladies lifting cars off their sons. I think that's probably because in extremis, the body can probably override the tendon organs cutting the power off and allowing you to do a maximal exertion, despite the fact that it's risking your own safety when you do that. I think there's probably another use of the tendon organs in terms of allocating when they're going to recruit particular muscle groups of fibres. You don't always have a full contraction of muscles, so they may well have a use of deciding when certain groups are going to fire. But from the point of view of the safety, we can think of them as, if you like, mechanical circuit breakers in there that cut the power off if the force is going to be too much and likely to damage the body. So, thinking about deep tendon reflexes, again, what we tend to do is C5 and 6. C5 is predominantly biceps. C6 is predominantly brachioradialis. 7 is triceps. 8 is fingers, which you can. Most people don't bother with it, but you can do it with the finger jerk. Knee is 3 and 4, and ankle jerk is S1 and 2. So they're the standard deep tendon reflexes that we tend to test. And that's where they are in the upper extremity: biceps, triceps, and brachioradialis. That's biceps, brachioradialis. Actually, that's a useful one to note. If you come down from your thumb and feel that little process on there, little styloid process, when you find that, just come up a bit and then you're on the tendon. Press on that and pull down, and that is the brachioradialis tendon, and that is what you're going to hit to trigger the brachioradialis reflex. Some people call it the supinator reflex, but it's not the supinator muscle, it's brachioradialis. What I have seen is people just doing, oh, just hit on there. If you just hit on there, yeah, you'll get a jerk out of it, but you don't know which muscle you've triggered off. It could be one of about 4 of them in there. If you're testing C6, you need to test brachioradialis, so you need to be on that right, correct tendon to do that. Triceps, just in there, and in the lower extremity, patella, and the ankle jerk, you can do it the way that they're doing it on there, or you can do it in the way that you can dorsiflex your foot and hit your own fingers. It's exactly the same test. You're stretching the gastrocs, whether you're doing it from the plantar flexing the foot or just directly on the tendon. It's exactly the same test. And you've got this thing of, you can, if you wish, grade the reflexes. So from 0, no response, 1, diminished, could be normal. You've all seen patients who it's very difficult to elicit reflexes, but you know there's nothing wrong with them. So that could be normal. 2 is what it would normally be classed as normal. 3 is a bit brisker, not necessarily pathological, but making you think that way. And 4 is definitely pathological, very brisk, overactive. You're quite likely to get clonus in the sense of the reflex carrying on a bit after it's been provoked from there. Again, we don't normally see people grading them in that way, but you can if you want to. Upper motor neuron versus lower. So weakness, you can get it in upper and in lower. Atrophy, that's muscle wasting. You tend not to get it in upper motor neurons, but you do get it in lower motor neurons. Fasciculations, not in upper, yes in lower. Reflexes tend to be increased in the sense of upper motor neuron lesions, because again, you've lost the inhibition from above, so they go a bit wild, but reduced in the sense of lower motor neuron because the power to that muscle has been cut off, so you don't get any effect. And tone tends to be increased with upper, as we've said, and decreased with lower. There are a few variations, like with an upper motor neuron lesion, you might get some atrophy due to the fact that the muscle has been disused, but that tends to come over a period of time, not fairly quickly like you would with a lower motor neuron. Cutaneous reflexes, plantar response, you're going to go with an appropriate implement. You're going to stroke up the lateral aspect of the sole from the heel up to the ball, curving medially across the ball of the foot, and you're looking for the movement of the big toe joint to go downwards, plantar flexion. Don't really care what happens to the rest of them as long as the big toe goes there. You need to watch out for the withdrawal reflex. People don't like having their soles tickled, so they tend to pull the whole foot away. But you need to be aware that that's not the same as an upgoing plantar. If that big toe moves upwards, then that's indicating that there might be an upper motor neuron lesion going on. The umbilical one, I don't know, I've got a picture of that. Oh, that's the plantar one. Yeah, that's the umbilicus one. So, if you come, this one's suggesting that there's the umbilicus there. This one's suggesting if you draw the stimulus towards the umbilicus moves to meet the stimulus. You'll often see it done also like a diamond around it, going across that way, and it goes towards you. Across that way, it goes towards you. Don't pull it that way, because skin drag will probably pull the umbilicus towards you anyway. It's not a very reliable reflex. If you've been overweight, if you've been pregnant, if you've had abdominal surgery, there's all sorts of things that can interfere with that reflex. So it's not a very valid one. Some people don't seem to have a very marked one anyway. But you'll see it in the books, so you may want to be aware of it. The reason for doing it at all is we said that we've done the reflexes in the upper extremity, which gets you down to about T8. And then you've done the reflexes in the lower extremity. We haven't got one for L1 and 2, we've got one for 3 and 4. But you get this sort of area between T8 and L3 that we don't really have much in the way of reflexes or tests to do for. So you can use those ones to get a sense of the integrity of, if the umbilicus is T10, then 8 and 9 is, or 9 and 8 going upwards is that area, and then 11 and 12 are down there. If you don't have a useful umbilical reflex, you can just get them, you can prod in their stomach and just ask them to use their stomach muscles to push against you, and that will also give you a sense of the integrity of that area. We're trying just to check all the way down that the circuitry is okay, all the way down from top to bottom. So that's pretty well the motor system. If we do the sensory system, we've got the ascending pathways. There's some other terminology here. You might hear things, first neuron or first order neuron, and synapse into second order neurons, and sometimes in the brain to third order neurons in there. So if we start from here, we've got receptors coming in, and in these cases it's to do with fine touch, proprioception, vibration. They're going into the body, into the dorsal columns, and they're going to go up into the medulla. So there's your first order neuron. They're going to synapse in there into your second order neuron, and crossing over and going up the opposite side of the body into the brain, synapsing onto a third order neuron and going up there. So it gets up to the sensory cortex like that. So they come in and cross in the medulla, like we were talking about the other ones crossing in the medulla, coming down. Then they're the pathways that are going through the dorsal columns. This one, you've got the pathways coming through from the spinothalamic tract. So these are different size fibres from different types of receptors that are coming in. They are synapsing at the level or within a few levels of where they come in, synapsing onto second order neurons and crossing locally at the spine, and then rising in the lateral spinothalamic tract up into the thalamus, where they're then going to synapse onto third order neurons and into the cortex there. So the different crossing points, this lot in the medulla and this lot down here, can give you means of localising where an injury might be. Because if you get an injury of the spinal cord going halfway through, it might affect, let's say at this level here, on this side, it might affect those pathways going up, but at the same level it would miss those pathways going up. So those modalities would be spared and those would be affected. And then of course you'd have to consider the other side of the body, as well. So you might get the dorsal columns on one side and the spinothalamic on the other side.
Sorry, what are depth, vibration, right touch? What are those ones?
Can I come on to that in a second? I'm going to.
Can I ask another quick question?
Yeah.
Is one so it's an ignorant question, is one particularly quicker than the other?
Yeah, they are different sizes. Effectively, the spinothalamic tract, these are going to be smaller fibres, so they're going to be slower reacting. The dorsal columns are going to be larger fibres. Often these ones that you need a quick response because it's something that's going to affect your balance or stability or position sense. So they will pass the information quicker so that the interneurons we talked about before can have their body make automatic corrections quickly before you fall over. So the pathways we've got in the dorsal columns, you've got, let me go back one. You've got this one here and this one there, and then the same on the other side. So the medial one is the gracilis, which is the pathway that the fibres going to the dorsal columns from the lower extremities go up. And then the lateral one is the cuneatus, which is the fibres that the upper extremity neurons go up. And those dorsal columns carry primarily vibration sense, joint position sense or proprioception, 2-point discrimination, graphesthesia and stereognosis. So all this is quite detailed information and is quite, it carries a lot of information which allows the brain to be have a very clear picture of what's going on. With the spinothalamic tract, it carries pain, and by pain we mean pinprick, nociception, that type of thing, and temperature, hot and cold. And the anterior spinothalamic tract carries less well-defined touch and also tickle and itch sensations. So this lot gives you a lot more information than this lot. And you need to think about the different types of stimulation you might be getting there, that might be provided and that then has to get through the system and up into the brain. Fine touch gives you this kind of information. The exact location, you know exactly where you've been touched. Effectively the shape and size and texture of what you've been touched with. So it could tell you if I touched you with a piece of sandpaper, it could pick up the roughness of that sandpaper compared to touching you with a smooth piece of wood or something like that. You'd be able to pick up that difference from touch. And also some degree of the movement there. If it's crude touch, you might know that you've been touched, but you probably wouldn't be able to describe very well what had touched you, and you might not even be able to describe exactly where you've been touched. You might know you've been touched, but that's about all. So you don't get a very good idea of where or what has touched you. And all this information comes from an array of different sensors in the skin. They're all specialised to detect whatever it is they're trying to detect. and they've all connected to the right size of neuron to carry that information in the right detail and at the right speed to where it's going. So this is why I think why I've gone on so much about this is that certainly the students, they talk about the dorsal columns, they talk about the spinothalamic tract, but those things are just within the spine. What they forget is that you've got this connection from the periphery to the spine. You almost get the sense that the students think it all goes in and up the spine and magically at the other end it's all sorted out as to where it goes. But it's actually got to be end to end, hasn't it? You've got to start with the right kind of receptor, take it along the right type of wire and to the right bit of the cable that's the spinal cord to end up in the right place up there. So it's quite a complex set of things that are all coming together, and you can visualise all these different things coming into the different tracks and going up in different ways. With all these different types of sensors that do their jobs, from pressure, pain, hot. There's not one temperature sensor. You've got a temperature sensor that senses cold and a temperature sensor that senses hot. So it's all quite cleverly done. And there's various different types of touch as well. Some give you very acute sensations, some give you a much cruder sensation. So you can distinguish between light touch, deep touch, position sense of whether a joint or a muscle is moving, the amount of force that's being provided, pain in terms of pinprick type thing from free nerve endings, temperature, crude touch, all going up different types of fibres and different pathways to get to where they want to go. Which is a long way of saying that when we are doing sensory testing, we need to test both parts of the system. So when we're doing spinothalamic tests, we tend to use pinprick. Pinprick is the pin, the neuro testing pins that Claire was shown before, have a specially designed end that's designed not to penetrate the skin, but to make a very small radius dent in it. And that triggers these free nerve endings. And that sends up the spinothalamic pathway. And the hot and cold sensation also goes up that pathway. So to test the spinothalamic pathway, you need to use either pinprick or temperature, and we would normally use pinprick. With the dorsal columns, and that pathway is sometimes called the medial lemniscus. You know, I said that lemniscus was another word like tract, collections of nerves in the central nervous system. That carries all these things: vibration, joint position sense, two-point discrete graphesthesia, sterignosis. So you can use one of these to test it. You don't need to use all of them. All we're doing is testing the pathway. If you get a good response from one, you don't need to do the others. If you get an equivocal response from one, you might want to try one of the others and see if that makes it any different.
What one do you normally use out though?
I tend to use pinprick for spinothalamic and joint position sense for
Is that where you ask them where, get them shut their eyes and ask them where it is in the space or something?
No, it's if we hold here and here, you just watch what I'm doing. I'm going to move your thumb down like that and up like that, okay? That is down and that is up. If we start in the middle, I want you to shut your eyes and tell me which way I'm moving. It's probably a good idea not to go down, up, down, as I predicted. down a bit more, up, maybe up a bit more, up a bit more. But can they track where you're going? And notice that I'm holding the side of, I'm supporting this bit, and I'm holding the side of the thumbnail. If I go that way, she can tell whether I'm pressing on the nail or the pad. So you want to go there, and the only thing that changes is the angle of that. And that's the joint position sets, the position of that joint, and she can check that they're good. That's the easiest one to use. But you can use vibration with a tuning fork. 2-point discrimination I'll come on to in a minute. Graphesthesia and stereognosis is clear. If you hold your hand out and close your eyes, what have I put into your hand? You can close it. You can close it.
Coin?
Yeah. Is it heads or tails? That's it. She could tell what I'd put in her hand by the feel of it. It could have been a paper clip, I don't know, a pencil sharpener, a key, anything like that. That is using that very informative data about the type of touch that's going on there and interpreting it and just deciding what it is without looking. Graphesthesia is, I'll use something different. Can I use your? If I was to, if I draw a figure of 8 like that, yeah, could you tell what I was drawing with your eyes closed? Okay. Now, I did it in that rather crude way because if I draw an A on her, if the A looks right to me, it's actually inverted to her. So if we're going to do that, I should be standing this way. Get the gist, does it? If you can sense what's being drawn on you can all try it in a minute anyway. But try and make it that you're drawing it in the sense that the patient could see it, because otherwise it makes.
Do you do that in each myotone, or do you just do that in the affected one?
Well, this would be dermatomes, not myotomes. Yeah. Actually, interesting question. A myotome was the muscles served by a single nerve root. A dermatome is the area of skin served by a single nerve root. So yes, you would do it in the dermatome you were interested in. You wouldn't necessarily have to do it in all the dermatomes because your patient would have probably limited the area of concern for you. But the one of interest, you could do it in that. But as I say, you don't need to do all of these things. If you've got it, one of them and you've got a good result from it, you know that the circuit's right.
It's interesting as well, isn't it, with different patients with thresholds. If you've been particularly sadistic, with the pinprick, one, know the difference between someone who uses their spinothalamic and someone who uses the reflex. It's straight away, isn't it? It's quite different thresholds people have.
Talking about dermatomes, that's a kind of dermatome map, which is all a bit difficult to get your head around in some cases. You've got the gist of it there. It kind of can make a bit more sense to you if you think of it that way as a quadruped. If you think of it as a quadruped, it kind of all roughly lines itself up in order. But, so we were probably wired up to be quadrupeds, and then it all changed a bit when we stood up on our hind legs. But it does kind of make a bit more sense of the numbering of them if you think of it as that way. But yeah, as was just said there, it's the area of skin served by a particular nerve root. So, spinothalamic gives you crude touch, pain and temperature, and also the afferent part of the superficial reflexes. Any reflex has got an afferent part and an efferent part, the input to the brain and the output away from the brain. So if you lost, the dorsal columns carry these things, which we mentioned before, the fine touch, the much more informative stuff. So if you've lost the dorsal columns, you might know that you've been touched through the crude touch bit of the spinothalamic, but you wouldn't have much in the way of information about where that was or what type of touch it was. So it's, you would use one test to do the spinothalamic and another test to do the dorsal columns.
And it's just like, how would you use the vibration? Would you put it on a particular part and say which bit am I?
Yeah, what we normally do is use bony prominences and effectively just say, can you feel this? Can you feel that? And I've got my tuning fork here. What do I have? Have you got one handy? I'll have to tip that whole thing out to find it. Oh, it's all right, there's one here, thanks. Yeah, which one do you use? Do you use the 1 to 8 hertz one, the long one? We tend to use two tuning forks. The long one, low frequency, 1 to 8 hertz for vibration. When you do this, the movement of each tine is relatively large, and it's quite a lot of mass, so it actually produces a vibratory force that you can feel. The smaller one is much shorter, much less mass moving faster, and it makes a noise, and you're hearing it rather than feeling it. I mean, you are feeling it too through the bones, but you're interested in the noise the small one makes. You're interested in the vibration this one makes. Now, to actually use it, what you do, you can say, can I borrow your... So if we maybe use that bony prominence there, I could just do, can you feel that? She says yes. What's that proved? Not a lot. Okay. If I do that, what can you feel? Bit of pressure. They might say it's cold, they might say it's metallic, they might say that. Okay, now if I do that, can you feel that buzzing?
Yes.
Okay, so now she knows what she's looking for. So what you're trying to do there is say, now I want to do this on the arm that you're complaining about. Can you feel that maybe down there? And perhaps she'd say no. There, no. There, yes. Okay. Well, we know the vibration sense is okay to there, but it's being lost from there. So you go from distal to proximal. Couldn't think of the word. Oh, the other thing that you might do, if you didn't believe them, you might say, close your eyes. Can you feel that?
Yeah.
Tell me when it stops. So if you can stop and start it and try and catch them out if you wanted to. Thanks. Right, neurotesting pins. You've got a protective cap. You take the cap off as the patient can see you, so they know that you're using a new one. It's not designed to break the skin, but it might do. So if you use something as a testing pin, dispose of it as a pin, dispose of it in a sharps box. Okay? And what you're going to do is just touch like that. We normally suggest you do it in little triplets, 1, 2, 3, just so if you touch once, you may just luck into a point between the nociceptors and they can't feel it. But the chances of you doing that 3 times is pretty remote. And if I use that as a bigger example, if I did that and slip my grip a bit, and then that and slip my grip a bit more, and then that and slip my grip a bit more, I've done basically a third of the pin each time. So that gives me an idea that I'm applying the same pressure each time. So you can let it slip through your fingers a bit, like that. And it is, you're not trying to drill a hole in the patient. You are just trying to provoke a little sense of a small radius dent in the arm, not something requiring stitches.
And do you get them to close your eyes and say yes? Say yes when you do it?
There's various ways of doing it. It's nice to, what I tend to do is, if I'm interested in the arms or something like that, I'll probably touch up there. Can you feel that as a pinprick? You're interested in not just feeling a touch, but feeling it as a pinprick. And just say, I'm going to ask, do that on your arm, I want you to tell me if it feels the same. And you might want to do one side and the other, and does it feel the same? And again, if you're not very trusting of the patient, you might ask them to close their eyes and say yes, and perhaps even point to where you're touching them. Because with this sort of accuracy, they should be able to point to where the pin is going. If they've lost the dorsal columns, they may not be able to do that.
Well, sometimes I do it with the cotton wool, and then I get them shut their eyes and just say pinprick or cotton wool.
Yeah, that's fine.
Is that...
Yeah, you can do that. I tend, again, dealing with the students, people seem to have this idea that if they do pinprick and cotton wool, they've tested everything. But as we've just explained, that isn't the case. You need to test both tracks. So I personally don't find the cotton wool much use. But if you want to do it like that, so the patient has got to distinguish between the two, that's great. Or you can even do it the blunt and the sharp end of the same thing, if you want to. But if you believe them, then the fact that they're telling you make you feel it like it was before, like it was a pinprick, that's fine. I think as osteopaths, we're probably less likely to have people coming to us and trying to kid us that there's something wrong, like they might do with a doctor. So we're probably less likely to try and catch them out in lies. But if you didn't trust what they were saying, yes, you could certainly do that. Tell me sharp or blunt, or sharp or soft, or whatever. Okay, so we've done that. I've just told you the procedure on there, so that's fine. Proprioception we've done, vibration we've done. 2-point discrimination. This is, you don't see these anymore. In the old days, hospital consultants used to go around with a pin in their lapel, and they use the same pin on each patient. And you probably, some of you have got the patella hammers with the little screwing thing with the pin on there. We're not supposed to use them anymore, because you're supposed to use it once and throw it away on there. But there were these things that were like dividers, and you were trying to find out how far apart they had to be before the patient could sense it as 2 touches compared to one touch, or how close together it could be and be felt as 1 touch. You can get the same thing by getting a paper clip and bending it or something. If you get a new paper clip out of a new box, open it out, and you can kind of open it or close it. And the principle of that is to see this kind of homunculus thing, the way that they are defined on the cortex. You can see that there's a whole lot of cortex with that part of the lips. Yeah? But if you look at that part of the back, it's virtually less giving you less neurological supply to that part of the back than there is just to the lips there. So the areas that have got the most neurological supply mapped onto the cortex will be able to tell you that 2 touches are separate when they're very, very close together, whereas in someone's back they might be that far apart. So if you're going to use 2-point discrimination, you need to know what to expect where you're actually using it at what part of the body. Or you can compare one side to the other in the patient. But that's what, if you want to use it, that's what you're doing. You have them apart so that you definitely know there's 2 touches and then move them together until the patient can only feel one, and see whether that seems right to you or not. So we've done all that. So on their finger pads and lips, you should be able to feel it as 2-3 millimetres apart. On the palm, it's a bit bigger, 8 to 15. On the shin or on the back, 30 or 40 millimetres. Just depending how much cortex is devoted to the sensation from that area. Graphesthesia we've done, stereognosis we've done, and I think we'll skip cerebellar testing for the moment because I think you've had enough. Why don't you pair up and practice some motor and sensory testing, and I'll wander around and try and help.